Hello and welcome to our session. Let's begin with a few housekeeping items. All attendees are muted and encouraged to use the QA box to ask questions. Raise your hand or use the chat function for technical assistance. We offer dental, medical, nursing, public health, CHES, and MCHES continuing education credits. To receive the credit, you must complete the survey like we've done in the previous sessions. The survey link will be posted at the end of each session. Dental, medical, and nursing credits are offered at session level and require a survey submission for each session. Public health and CHES/MCHES credits are offered for only full-day symposium and require one survey submission. So for our lovely speaker is Dr. Michael Ganon. Dr. Ganon is a family practice physician and addiction medicine consultant at Zufall Health, where he is committed to expanding and enhancing the care of people with substance use disorders. Prior to joining Zufall, he ran an addiction medicine program for rural and underserved patients in Northwest New Jersey. Dr. Ganon's 35-year career also includes clinical and leadership roles with an emergency department, a detox and rehab center, and an outpatient treatment program. Board certified in family medicine and addiction medicine, Dr. Ganon earned his medical degree from UMDNJ of osteopathic medicine. And at the conclusion of this program, participants will be able to identify the common challenges faced by marginalized groups in achieving dental and medical treatment equity and inclusion, understand the physiological and social economic relationship between dental issues and substance use disorders and how each condition can affect the other. Learn the general adverse effect of substance use on dental health. Become familiar with how specific commonly misused drugs and alcohol affect dentition. And assess the potential impacts, positive and negative, of medication use to treat substance use disorder. Now, Dr. Ganon, it is all up to you.
Thank you so much for that introduction. I am not seeing my slides. May I have the first slide, please? Thank you very much. And the next slide, please. Good afternoon. So glad to be here, and thank you for that kind introduction. When I was asked to speak today, the initial topic that I was asked to speak about was the effect of medications that we use for addiction treatment on dental health and on causing dental problems. That would be a very short discussion, but luckily I saw the subtitle on today's discussion. It's Beyond the Smile, Wellness, Prevention, and Equity. And equity in substance use treatment is something that I have been fighting for in my practice for the last getting on 7 years that I've had an active addiction medicine practice. And I have been seeing over and over the incredible inequities and disparities in care for folks with substance use disorders. And I, of course, see the problems with dental health that follow substance use. In my research for this presentation, I came to understand that it is not only the substance use problems that affect dental health, but how important dental health is to impacting substance use. There are a lot of similarities in barriers to care and exclusionary care to both populations suffering or struggling with dental health disorders and substance use disorders. And these challenges largely revolve around inequities, inequitable care that is available in today's environment for both of those problems. We will, of course, talk about the original topic, which is the effect of medications on that we use for addiction treatment on dental health problems, but we will also be talking about the effect or impact of illicit drug use or misused drugs in their impact on dental health. And we will end with a very optimistic view of the availability of ways to improve our treatment of both. Next slide, please. As I said, I came to understand in my research for this presentation that it is not just substance use problems that adversely affect dental health, but rather problems with dental health and inequities in oral care that negatively impact substance use. It is what I call bidirectional. One impacts the other. Substance use problems are a subset of mental health. They're a subset of behavioral health. And it's said that about 30% of patients with substance use disorders have significant co-occurring, mental health disorders. How can mental health disorders adversely affect dental health? They go together. Substance use, mental health go together, and they adversely affect dental health in many, many ways. But if you think about somebody with severe depression, something that I see all the time, severe depression makes people neglect their regular medical care. Folks are so deeply depressed, they don't even take care of their daily needs. They don't shower, they don't brush their teeth. They certainly are not making appointments to go to the doctor or dentist. And it affects their self-esteem. When we have low self-esteem, our social functions suffer. And when our social functions suffer, then our ability to get employment or even pursue employment, our ability to pursue higher education, our ability to just do things to improve the lot of our life are adversely impacted. Of course, substance use itself affects dental health in many, many ways, and we'll go into them in much greater detail later. We know that dental pain may cause people to use substances to relieve that pain, but emotional pain also causes people to use substances to relieve that pain. It's the self-medication model of substance use. People use substances to relieve their anxiety or to relieve their depression, or sometimes to improve their focus and concentration. But again, in an optimistic way, if we approach the problems of dental health and we approach the problems of substance use, and preferably if we approach them together, we have a better chance of being a light to our patients, as the last speaker alluded to. Next slide, please. There are a lot of commonalities in disparities in care and in difficulties that people suffering with both dental health problems and substance use problems face. Both are historically woefully undertreated in the United States. Both incur or impart significantly high costs to care, and they contribute very strongly to the national healthcare debt, which we are all responsible for being stewards of, trying to decrease national healthcare costs. And significant financial barriers to care exist in both settings, both dental health and substance use settings. We will talk about the disparities and inequities of care in more detail as we move forward. I spent most of my career in the emergency department, and in the emergency department, I saw certainly lots of dental problems and lots of substance use problems. And I did the best I could for those folks, but emergency departments are a terrible place to take care of dental health problems and substance use problems. It is incredibly costly, incredibly inefficient. Episodic care is never as successful as ongoing, continuous care for problems that are extended in their impact on our health. Excuse me. And frankly, most providers in most emergency departments are not the best people, the most qualified people, or even the most willing people to be taking care of dental problems or substance use problems. Both issues have a profound effect on our emotional health, our self-esteem, and our overall health. And as I said before, we can do better. And we'll talk about that as we end this discussion. Next slide, please. In view of the disparities in care, there are two main categories, in my view, of disparities or inequities in care. One are external barriers. These are basically systemic problems. I talk about marginalized groups, and I talk about socioeconomic factors, the social determinants of health. Then there are internal barriers, which we'll talk about in some detail later. Those are biases, prejudices, preconceived notions, as the first speaker today mentioned, that lead to stigma if we generalize them to larger groups. The marginalized groups are listed on the slide that you're looking at. And I think most of you are familiar with the groups that we consider marginalized. There are two that have impacted my patients most greatly. The first are racial and ethnic disparities. And apparently, it's not just my patients who are marginalized in terms of racial and ethnic disparities to care. If we look across the entire United States in 2019, that was before the pandemic. And most of the data that I use is before the pandemic because the pandemic changed access to care in many, many ways. Most negative, but with the advent of telehealth and the increasing use of telehealth and telemedicine in both substance use treatment and dental care, there were some positives to come out of the COVID pandemic. But before the pandemic, in the year 2019, a study showed that only half or nearly half of white individuals had a dental visit within a year, compared to only 28% of Black individuals. That points up the significant disparities in dental care. In substance use treatment, there was a study done in Louisiana. It happened to be in rural Louisiana, and as we'll see in a second, rural disparities are huge, and it was like a double whammy. If you were a Black individual in rural Louisiana, you were 4 times less likely to receive the gold standard of care for opiate use disorder than if you were a white resident in the same area. Geographic boundaries are huge. About 2/3 of rural areas in this country are designated as dental health shortage areas. And if you happen to live in one of those rural areas, you are twice as likely to be missing all of your teeth compared to if you lived in an urban or a suburban setting. Up until a couple of years ago, doctors and other health professionals needed a special waiver or a special certification to be able to provide buprenorphine, the gold standard treatment for opiate use disorder. And there were tremendous disparities in care to begin with because many providers in many places were unwilling to provide that care. But the disparities were huge when you compare rural areas to urban or suburban settings, with 56% of rural counties having none, 0 providers of buprenorphine, the gold standard treatment for opiate use disorder, versus 19% across the whole country. I mentioned earlier that a significant percentage of people with substance use disorders have co-occurring mental health disorders. It approaches 30% in most studies that I have looked at, and 90% of rural counties had no psychiatrist, not one. Can you imagine living in a rural area and having, say, you're having a heart attack or you have bad heart disease, and there is no cardiologist in your county, no cardiologist. For many years, after I started my practice in Northwestern New Jersey, I was the only provider of addiction treatment with a full-time addiction medicine practice in 2 counties. People had to come, I was it, the only choice. So that is a significant barrier and points up a significant disparity in care. Next slide, please. Next slide, thanks. And the second external barrier that I mentioned are the social determinants of health. The 2 or 3 that impact my patients the most are income and insurance coverage, geographic location, and public transportation. Medicaid coverage, I was surprised to find, varies tremendously in terms of what they cover for dental care state to state. Some states have very little dental care provided, if any, under Medicaid, and some have fairly comprehensive coverage for Medicaid. I think it's fair to say that we all believe that everybody should have equal access to dental care, to substance use treatment. And if the coverage is varying from state to state, that is a significant disparity, a significant inequity. I see that in my own practice with buprenorphine. And again, the disparities are huge. If you have Medicaid, only 38% of buprenorphine prescribers will accept your insurance to take care of you, leaving people having a very hard time finding a provider. I mean, if you live in a rural area and there's one provider and that provider doesn't accept Medicaid and that's your insurance, you're pretty much out of luck. Even less accept Medicare. 77% of outpatient treatment programs, that's methadone clinics basically, will accept both, but there are entire states that only have 1 methadone clinic or 2 methadone clinics. Wyoming, South Dakota, North Dakota, Montana, each have either 1 or 2 methadone clinics for the entire state. So if you live in those states and you do not have access to transportation, public transportation being limited in most rural areas, you basically can't get to a methadone clinic. And those states may not have a single buprenorphine provider, or if they do, may not have one that's willing to accept your insurance. Next slide, please. So what we see is that it's not black or white. It's not like either you can get care or you can't get care. It's a spectrum. Maybe you have great insurance, but you can't find a doctor or a dentist who will take your insurance. Maybe you have great insurance and find a doctor or a dentist who is able to meet your needs, but you can't get to them because you have no transportation. And ultimately, if you do get to a provider who does accept your insurance and is able to meet your needs, then you may not get great care. Why? Well, we're going to talk about that in a second. Stigma, prejudice, bias, different ways that we look at different people. I have had patients go to a doctor, a specialist, say for, I'm thinking offhand, recently, one that went to a doctor for severe liver disease, a consequence of their ongoing substance use. And they heard to the side, doctor say to nurse, "Oh, another addict." They needed the care, but they will never go back. They will not go back. And that's the only hepatologist that I know that would take care of them. They will not go back. We sometimes discriminate unknowingly, making judgments, preconceived notions that the first speaker mentioned, that we have about patients. We may judge our patients based on their intellect, or we may judge our patients based on our feeling about their ability to understand or follow up or be compliant with care, or their willingness to take medication as it's prescribed, as opposed to however they feel like it. And we may offer limited treatment, limited types of treatment based on our own perception of what that patient will or can do. We may actually change how invasive our care is based on our judgment, our own internal judgment, having nothing to do with what's true for that patient about what we will do for that patient. Here's an example. If I think, well, I'm not a dentist, so it wouldn't be if I think, but if a dental provider thinks that a root canal and a crown might take 3 or 4 visits, and they decide for the patient, not that we should ever be deciding for our patients, but they decide for the patient that they are unlikely to be able to follow up with a course of care which will extend over 3 or 4 visits, or maybe that they have some of those barriers to care, those social determinants of care that will limit their ability to follow up. We may do a dental extraction instead of a root canal, where somebody with different ability or capabilities for follow-up would get the full root canal and crown. In my own practice, sometimes I feel like a patient may not be able to comply with care, may not be willing to take good care of their medication, may not be willing or able to be relied upon to take medication every day. And if I were to do that, I may only offer them injectable medication instead of the tablet or film-based medication that you use every day that I would give to everybody else. And that would be wrong, and I wouldn't do it. But there are providers who use their own preconceived notions to determine patient care, rather than providing equitable and inclusive care to all, letting the patient make the decision. Next slide, please. Where does this come from? Where do our preconceived notions and our biases come from? And we all like to think that we are unbiased. And I'm wondering and hoping if everybody in the audience is willing to give themselves an honest self-appraisal. Unless we can acknowledge our own prejudices, our own biases, because we all have them, and unless we can then push those biases and prejudices to the side so that they do not impact our care, we will not be able to offer the help to our patients, be the light to our patients that we want to be. Let me give you an example of biases to help you understand that you might have them. Picture yourself coming out of Chuck E. Cheese with your toddler, holding your toddler by the hand, and you're walking into a dark parking garage. In that parking garage, you see a 20-ish-year-old man, disheveled, multiply tattooed, heavily pierced, pants down around his butt, and he is approaching you very quickly. Versus you see a 30-year-old woman in business attire in the same setting, approaching you in the same way. Do you feel differently? Probably. Let's suppose you are a medical or dental professional and you're starting your own practice, you're starting your own office, and you have two applications of people that are equally educated and equally qualified to be sitting at your front desk, to be the greeting person, the reception person. One is a very attractive person with a beautiful smile. One is, frankly, unattractive. And they either have they have a good smile, but their teeth are terribly decayed. Or, as with that first speaker, Dr. Daywalker, what a great presentation that was. They're covering up their mouth all the time because they're embarrassed, they're ashamed. Which one are you likely to hire? Those are biases. I have run into doctors who flat out do not like people who use drugs. When my practice got very busy, I asked a former emergency department colleague of mine if he would like to join me and help me a little bit with taking care of my patients. His answer was 4 words. They were the last 4 words he ever spoke to me. I hate those people. Can you believe that? I did ask him why. He said, they ruin my shift. Bias, for sure. I was talking to an addiction medicine colleague of mine, and we were talking about some of the difficulties of running a solo practice in addiction medicine. And she said, you know how these people are. These people? Bad. I went to my dentist recently. Apparently, there are dentists who don't like people who use drugs. I went to my dentist recently. I had a bad toothache. It was the first toothache I ever had in my life. It was pretty bad. And she looked in my mouth and she couldn't see anything. And she did an x-ray and she couldn't see anything. And she said, well, it's probably a microfracture, which sounded crazy to me. But that's what she said. And she said, would you like some pain medicine? And I will refer you to an endodontist, both perfectly appropriate. I had a patient not that long ago who went to a different dentist with the same problem. Bad toothache, couldn't find anything. The dentist called me up when the patient asked for pain medicine and said, I think this guy's a drug seeker. Well, he wasn't. He had never used opiates, never in his life. He had never used sedative hypnotics ever in his life. He had a problem with cocaine use, which was in stable remission. But people who use drugs are viewed differently. And if we view groups as differently, it creates stigma. Next slide, please. Next slide, please. Thank you. Where do these come from? Because I think that particularly with the toddler example I gave you first, or excuse me, maybe with the question about who you would hire, I hope that you all realize that we do view different people in different ways. And I said that we need to acknowledge it and understand it. Where does it come from? It comes from the fact that the brain is excellent at creating shortcuts through patterns and categorization. And it does this so that we don't have to think about things or explore all the options in things when we might be in a situation which might endanger us. Think back to long ago times, or think to tribal societies, where actually different people that look different or people that act different may actually be coming to harm you. They may be coming to steal your crops or actually do harm to you, take your land. And so our brain has developed so that we recognize different and we recognize scary and we instantly act on it rather than exploring it and making decisions based on logic and rational thought. There are 4 of these that behavioral psychologists use to explain this. There was a bunch of them, but 4 that really apply here. The first is the faulty or hasty generalization. And that would be if the first 3 patients that I ever saw in the emergency department with a substance use disorder were nasty and mean, I make a generalization and I go, people who use who have substance use disorders are nasty and mean. I never want to see them again. We take those patterns and characteristics and categorize them, and that creates the representative heuristic. It's basically judging a book by its cover. Things that are recent, frequent, negative, or extreme bias us against those things. When you see, if you're driving down the road, like 70 miles an hour, it's a beautiful day, you got the car radio on, everything's cool, and you see a car accident, bad car accident, do you not slow down for the next several miles? Well, your chances of getting in an accident in the next several miles are no greater than they were before you saw the accident, but it's extreme and it's negative, and we act on it. And then we confirm our pre-existing beliefs. This is probably most easily understood by looking at the political realm. If you're a very conservative person, I mean, like way on the right side of things, you probably watch Fox News, and everything that they say confirms what you think. If, on the other hand, you're a very progressive or liberal person, you probably don't watch Fox News. You probably watch whatever, MSNBC, and they confirm everything you think. But we all know that the truth almost always lies somewhere in between. The shortcuts serve us well on the average because they keep us safe from other and different. But we have to not let them get in the way of taking care of the person that is in front of us that is seeking our help. Next slide, please. Substance use impacts dental health in many, many ways. And we're going to talk about some specific substances here in a moment. But according to the NIH, the National Institute of Health, dental problems are actually among the most common health problems linked to drug addiction. I mean, I think of hepatitis C, I think of HIV, I think of overdose, but dental problems actually are a much more frequent problem among those who use drugs. Substance use affects all systems in the body, every system, but as it applies to our dental health, the most important ones are the cardiovascular system, because good circulation is clearly necessary to keep healthy teeth, our immune system to keep our teeth and our gums from getting infected, and our skeletal system, of course, because the teeth are part of our skeletal system and because they are rooted in our skeleton. And so dental integrity depends completely on skeletal health. And the specific issues that occur in the mouth from substance use are xerostomia or dry mouth, dental caries, periodontal disease, and tooth loss. Next slide, please. Substance use in general leads to chaos in our life. Now, not all substance use. I mean, if you smoke marijuana twice a week or maybe a little bit at night to relax, that is unlikely to affect your dental health significantly, and it's not going to lead to a chaotic lifestyle. But changes in your lifestyle, negative impacts on your lifestyle, are the key diagnostic criteria for a substance use disorder. So active addiction leads to a chaotic lifestyle, and a chaotic lifestyle leads to carelessness. Carelessness leads to oral and facial injuries. And when we're in active addiction, clearly we don't prioritize our oral and medical care, which has negative impacts on all of our medical well-being, but has particular impacts on oral hygiene and in neglect of dental care. Next slide, please. To talk about some specific substances. Marijuana, very recently, in the last couple of years, overtook alcohol as the #1 substance that is used on a daily or near daily basis. About 18 million Americans use marijuana daily or near daily versus about 15 million Americans who use alcohol at the same frequency. Dry mouth is a very common problem associated with marijuana use, and we know that saliva serves a very important function in maintaining our dental health. It washes away food, particles, and sweets from the teeth and gums to reduce the risk of dental caries and periodontal disease. And everybody's heard about or experienced the munchies with marijuana use. It's a real thing. It's legitimate. And the munchies are usually toward junk food and sweet food. And we all know that those can impact your teeth in a very negative way. Marijuana smoke, as tobacco smoke, has a lot of carcinogenic hydrocarbons, and carcinogenic hydrocarbons are intimately linked with leukoplakia, which is a precancerous lesion. I'm not aware of any hard data that links marijuana smoking to cancer, but we know that it causes precancer in the oral cavity. Next, please. Alcohol, as I said, now the second most common substance used daily or near daily. Alcohol is directly toxic to the salivary glands. Some alcohols are acid, some alcohols are sweet, and the acid can do damage to your enamel, and the sweets, of course, increase dental caries. There are much higher rates of smoking among those with substance use disorders, alcohol use disorder perhaps particularly so, with about 70% of people who are in a substance use treatment program are nicotine smokers or cigarette smokers, and only about 21% of the general population. Opiates, they get all the press, right? We hear a lot about it, we see a lot about it, we talk a lot about it. They're much less likely to impact dentition in a negative way than alcohol is, but they impart their negative impact on dentition through xerostomia and in males through decreased testosterone. Keep in mind, those are what we call class effects of opiates. That means every opiate, whether we're prescribing them or whether they're used illicitly, will cause those effects. Next slide, please. MDMA or Molly is Molly in the powder or crystal form. It's ecstasy in the tablet form. Causes not only severe dry mouth, but very persistent dry mouth. And again, the decrease in saliva increases the risk of dental caries. Bruxism is grinding of the teeth. And frequent Molly users often have bruxism, which causes mechanical trauma to the teeth, which leads to dental erosions or enamel erosions much greater than in others. Cocaine causes increased oral leukoplakia. Next slide, please. Methamphetamine is the classic illicit substance that affects the teeth in a negative way. Some of this comes through xerostomia, but most of it comes through a decrease in salivary buffering capacity, the ability to neutralize acids in what we eat, in what we drink, and in general. That decreased buffering capacity happens no matter how we use methamphetamine. If we inject it, if we use it nasally, if we ingest it, if we smoke it, it doesn't matter. Salivary buffering capacity is decreased greatly, and it causes severe problems to the teeth. If we use methamphetamine either via the smoked route or the inhaled route, it directly damages the teeth. And the cavity formation that occurs with methamphetamine is kind of unique. It affects, mostly the area around the gums and on the buccal or cheek aspect of the mouth, and is typically between the central or lateral incisors. Significantly increased risk of tooth decay in methamphetamine users. Next, please. Let's move on to the medications that we use to treat opiate use disorder. Buprenorphine is the number one medication that we use in outpatient settings. It's weakly acidic. Keep in mind, though, that a pH of 3.4 is 10 times less acidic than the pH of Coca-Cola. Buprenorphine, and as a class effect, because it is an opiate, but a different kind of opiate, causes the xerostomia and the testosterone decrease in males. As much of a surprise to most of us in the addiction medicine community, the FDA in 2022 came up with a special warning about buprenorphine. Next slide, please. They said that transmucosal forms of buprenorphine could damage your teeth. Transmucosal are the kind we put in our mouth, as opposed to injectable or implantable. The Society of Addiction Medicine, taken by surprise, called for an immediate withdrawal of that warning to the FDA, because we recognized immediately that it would give people who were ambivalent about treatment to begin with a reason not to use this life-saving drug. Plus, the basis for the warning was based on only 305 people that were reported by their doctor to the FDA to have had a dental problem presumed to be due to buprenorphine, while there are 800,000 people using buprenorphine daily. And it failed to take into account opiate use disorder, use of co-occurring opiate use and methamphetamine use. Next, please. The FDA basically recommended see a dentist soon after you start buprenorphine and practice good oral hygiene. Next slide, please. Methadone is the second most commonly medication used to treat opiate use disorder. Methadone, as the class effect, causes xerostomia, causes decreased testosterone, but it is provided in methadone clinics in a sweet cherry syrup. And the sweet cherry syrup is taken usually in the morning, and then people just walk around with it on their teeth all day. And it may well be that causes any damage to the dentition. The decreased testosterone is, again, a class effect of all opiates. Next, please. And next, please. I'm going to skip over naltrexone, at least not the detail of naltrexone. Thanks. Naltrexone is a drug that we use, a medication that we use orally for alcohol use disorder, and either injectably for alcohol use disorder or opiate use disorder, and it occasionally causes xerostomia or toothaches, but not much. The key takeaway here is that medications save lives, but yes, they can have a negative impact on oral health. The impact on oral health is something that we recognize, something that can be mitigated or somewhat prevented by good oral care and good dental care. But while studies of medications for opiate use disorder are kind of all over the place as far as their benefit, somewhere between 35 and 70% reductions will occur in mortality, overdose, hepatitis C, HIV, incarceration rates, recidivism, if we just treat opiate use disorder versus the relatively small impact on teeth. Next, please. I'm going to skip over the next two slides. Thank you. The two slides that we just skipped over were really very basic. They were testimonials. One former methamphetamine user was unable to get her teeth repaired. She had terrible dentition, and it impacted her in many ways. She was unable to go to meetings. She was unable to appear in social settings. She was unwilling and unable to seek employment because she was so embarrassed about her teeth. The other was a young lady who had been using methamphetamine from the time she was 13 till the time she was 39 and got her teeth fixed and was able to engage fully in a wonderful social life and impacted her educational situation positively as well. Project Floss was an incredible project that shows that bidirectionality between dental problems and substance use problems. You know, I'm substance use centered. And so I always look at, well, how does substance use treatment improve everything else? This was a study that looked the opposite way, was what would happen if we gave great dental care to people who had a substance use disorder? Would it positively impact their substance use? And the study was great. They took, I think it was about 300 people that had completed their initial course of treatment, presumably detox and rehab, excuse me, and they put them in sober living, 300 in one sober living, 300 in another sober living, and they gave one sober living, and the groups were age matched, race matched, gender matched. They took one group and they gave them comprehensive dental care. They took the other group and they gave them no dental care, although they could access dental care outside of their sober living if they wished. The study carried on, I believe, a year. And at the end of that year, the group that received comprehensive dental care completed substance use treatment at a much higher rate, were employed at a much higher rate, were abstinent at a much higher rate, and had a significantly decreased rate of homelessness. Not only upon qualitative assessment of the benefits was the life of those people who got dental care greatly improved, but interestingly, the satisfaction among their care providers was greatly increased as well. Next slide, please.
Hi, Dr. Gannon. You do have to start taking questions if you would like.
Oh, okay. Can we just skip to the last slide, please?
Sure.
Next to last. Thank you. I wonder if one person can make a change. And before this was a picture of Dr. Bob Zufall, who founded the Dover Free Clinic in 1990. About 10 years later, a dental clinic was added. In 2022, Zufall Health, the original Dover Free Clinic, was 7 clinics and expanded their care in a very, very intentional way to improve, enhance, expand the care of those with substance use disorders. And just 2 years later, they had essentially a fully integrated program for dental health, substance use treatment, mental health, behavioral care, and so many other things. It can be done. One person can make a change. Bob Zufall did it. We can do it too. Thanks.
Thank you so much, Dr. Gannon, for your wonderful presentation. I know I have a question, so I'm going to start because that's what I had one. And it was actually one that you had asked me before. So with the buphenyline, why does the usual product not have the same warning as the one that's injected?
I think 2 reasons, mainly. The first is that the oral product is left in the mouth, and that's the most commonly used one by far. The oral product is left in the mouth, so it's exposed to the teeth for a long time, maybe 20 minutes before it's completely dissolved. And 20 minutes is a long time to expose acid to the teeth. And that's not the case, obviously, with the injectable form. I think it's possible that the injectable form, it's likely, in fact, that the injectable form will cause the decreased testosterone that causes decreased bone density. But I think that we don't have enough data because A, it's not been around long enough, and B, even though it's been around, it hasn't been in wide enough use for us to have great data on it.
And also, what do you attribute to the benefits in recovery seen in Project Floss with the group who did receive oral care versus the people that did not receive the comprehensive oral care as they did in the recovery?
Yeah, as I think I said, that result took me by surprise. I know the substance use treatment greatly benefits all other aspects of somebody's health, including obviously their dental care, but it didn't occur to me that taking good care of people's dental health would so much improve their substance use treatment and success in their treatment. I think it goes back to the bidirectionality, how one thing impacts the other. If someone has terrible dentition and they're unable to smile or unwilling to smile, they're ashamed of their smile, they're not going out and trying to get a job. And if you're jobless, you might end up homeless. If you're homeless, you might go back to substance use because your life is terrible. And so if you can't get a job, if you can't pursue higher education, if people look at you like, ugh, you might go back to using substances. In fact, most people would if they are subject to stigma, negative interactions with people without regard to their substance use, prejudice, bias. Yeah. And so I think that when we improve people's smiles and we improve their self-esteem and we improve their self-confidence, it has that positive impact on their substance use. It was dramatic.
Thank you so much, Dr. Ganon, and to everyone who attended today's presentation. Please remember that in order to complete this, you must take your survey, and you will automatically now be routed back to the lobby to join the next session, which begins. And thank you so